Hello, everybody. We're live again for episode 3 of MHTV. It's at an earlier time of 1 p.m. today because we're interviewing Rachel Bowes in Australia, and it's evening over there. I'm Vanessa Garrity, and I will be presenting today along with my colleague, Nikki Lambert. I'm a mental health nurse, and I run We Mental Health Nurses on Twitter. Nikki, do you want to introduce yourself?
Hello, I'm a mental health nurse and I teach nurses.
Okay, and we've got Rachel Bowes with us. Hello, Rachel. Rachel's live with us in Sydney at the moment, and it's night time over there, isn't it?
Hi, yes it is. It's 10 p.m, so I'm trying to keep myself awake with caffeine.
Yeah.
Here with you, it's exciting.
Yeah, it's great to have you here. And Nikki, you're going to be doing the social media today. Do you want to say a few words?
I am. It's my first time on social media, so I'm quite excited. You can watch us live and join in the debate if you go to the Unite MHNA live page, and you can like and follow us there. You can ask any question. If you're looking for us on Twitter, it's #MHTV. Thanks.
Thank you. Okay, so we'll go straight into the first question then, Rachel, if that's okay with you. And yeah. I guess for me, it's really exciting to interview you. We worked together, didn't we, a long time ago? I can't remember how long, but I think it must be going on for 15, 20 years now, probably.
I think it's nearly 20. I think it's nearly 20.
Yeah.
When I was thinking about it.
Yeah, so lots has changed since then, and obviously you're now living in Australia and you've been there quite a few years now, haven't you, as a mental health nurse? So I guess that brings me to my first question really is what's it like as a mental health nurse who trained in the UK, now living and working in Australia?
It's lovely. You know, Australia's a really great place. It's really cheesy because everyone thinks, oh, it's sunny, but actually it's sunny a lot of the time and it's really, really lovely. And so, you know, the whole weather and lifestyle thing, I know we joke about it, but actually is a really lovely place to live and to work and to have a family. Like I've really appreciated the ability to be outside so much. Like you know, it's great for your mental health to be out in and walking about and being in beautiful places, and there is an abundance of that here. So I feel really lucky to live in this lovely place that I do, and it's a great place to work. You know, I think the actual profession of mental health nursing is probably not quite where it's at in the UK. I think I noticed that when I first came out here, and it hasn't really changed, and it feels just like everything is just a few years behind. So I think perhaps we in Australia don't quite have the innovation that happens in the UK. And, you know, and obviously there are exceptions to that because there's some really great clinicians working here. But I think generally we don't seem to generate as much of the kind of new practice and evidence base in the way that I felt like happened when I worked in the UK. I think that's a little bit to do with the training. I know we were going to talk about that a bit later, but the fact that everyone does a normal nursing degree and can either go and work in a mental health setting or any other setting, and have to have that specialist postgraduate. You can get that and be a specialist mental health nurse, but you don't need to have done that to work in mental health. And I do wonder sometimes if that a smaller workforce of people who are specialist mental health nurses means that there just isn't the same opportunity to be innovative and influential as you might do somewhere else. So that is only my own personal take on it. I think there might be some people who disagree, but my general sense is that it feels being here now is a bit like when I worked back in the UK kind of 10, 15 years ago. It kind of feels like not much is different really, but the pay is better. That's a really significant thing here, even accounting for the cost of living. Nurses are paid better across the board here.
that point about generic mental health nursing is really interesting, isn't it? Because there's been lots of debate in the last few years about us moving to a more generic mental health nursing programme. And Nikki, I wondered if you had any thoughts about that.
You've just launched the first grenade of the episode. I am a stalwart mental health nurse. I've been a mental health nurse for 20 years. I come from a family of adult nurses and doctors, and I never even considered it, not for a second. If that had been my only option, I wouldn't have done it. Not even remotely, because it didn't speak to me. And I think different populations, when you serve different populations, different characteristics are probably needed. So whilst I'm not saying at all that all mental health nurses are the same, but I think we have a certain approach which unites us all, and I would say globally as well, having been to conferences all over and worked in Australia as well, in a way that we just approach situations slightly differently. And I think that's right, because the qualities that make you a great mental health nurse would make you a terrible theatre nurse, in the surgical situation. And the qualities that make you amazing at that might not translate into working with children or people with learning disabilities. And the other thing I worry about, seeing how the learning disability field has been so undermined. You look now at the number of learning disability deaths, and I cannot help but think that there's a connection there with people who have a specialty and a specialist interest. There as advocates, there as practitioners, they're pushing research, pushing education forward. When they're not there, that population suffers, I think. And I would hate to see that happen for the people who I work with and who I love to work with. I wouldn't want them to have a different type of care because of it. Look, that was the polite, calm down, quiet version.
And I think I agree with most of what you said, really. That I don't agree with.
It's funny though, isn't it? Because I was one of the first years that did Project 2000, and I remember how terribly people spoke about us and how we were going to be this generation of nurses that were overeducated but a bit clueless. And I remember finding it all really offensive at the time. And actually, when I then went on to work and be a mental health nurse, some of the best nurses I worked with were those people that did Project 2000. And it just, I don't know. And I think none of the kind of angst that people had about that seemed to translate into real differences in practice. I think people could always find them if they were looking for them, but equally we could easily find examples of people who trained 10 years before us who were equally woeful or equally brilliant. So funny, isn't it, how there's such a cyclical pattern to these things.
Yeah, I would agree. I mean, I think the disadvantage with Project 2000 for me was that whilst we covered physical healthcare, as a mental health nurse, it was never framed in a way as this is going to be something that's useful to you as the mental health nurse. It was almost that you have to do the same as what the general nurses are doing. So it was never made to feel relevant. Whereas now, hindsight of 20 odd years, I think if only I'd appreciated how that was kind of relevant to my practice. I think it was just because it was at the beginning of that wave of change, wasn't it? But
well, we've got a new curriculum, don't forget, in the UK now, which balances things out technically a little bit better. So this expectation that mental health nurses need to know about how people's bodies work to be able to actually sort of honour someone's recovery. There's no point being a great therapist and watching somebody die of diabetes and not say anything.
Yeah, exactly.
In the same way, sort of mental adult and child nurses need to think about how they can support mental well-being and flourishing. So for me, I think hopefully we'll see things get better. And work together, because it's a false, because you're saying like Rachel, you're saying about the kind of false fight between are you kind or are you smart? It's like, well, you can be both.
Exactly.
Yeah, absolutely.
Exactly. Yeah. And you should be both, to be a mental health nurse. Yeah. So I suppose what I'm interested in, I know, Nikki, you've lived in Australia as well, but I'm relatively naive about the Australian system. How does it work? So I know Lifeline's a charity, isn't it? So how does it work generally? Are there statutory services? How would someone access mental health services in Australia?
In lots of ways, it's the same as at home. In the UK, like there's a lot of public mental health services which are like the NHS. They're kind of provided under Medicare, which is free at the point of delivery healthcare for anyone who needs to use it. I mean, they're a bit bleak, some of the public mental health services that I've been involved with, particularly when I first came to Australia. You know, some of the buildings were really old. Again, a bit like it was 15, 20 years ago at home, before we went through that whole episode of the reprovision and kind of building all the new hospitals and closing. It feels like, again, that's something that's taken a while to catch up with here. And I think there is a little more of a two-tier system, because a lot more people have private health cover in Australia. It's quite a normal thing to have, and a lot of people have mental health cover as part of that. So quite a lot of people who would usually perhaps be admitted as an informal patient to a ward for, you know, an episode of depression or anxiety, in the public health service, they probably wouldn't even get into hospital. Like, they're not ill enough right now, they would go to a private hospital. So there is that more of a two-tier system. So a lot of people do use private healthcare as well as the public mental health system. But in other ways, it's very much the same. You know, there's the community mental health teams, and there's kind of access to the psychological therapies through your GP and through the Medicare program, which is free. So there's a lot of similarities. I think the difference is the increased use of private facilities. That is probably a lot more than people would use back in the UK. And there is a huge not-for-profit and charitable sector in mental health that I suppose prop up some of that system as well.
That's interesting. And what about in terms of social care and social equality? You know, I'm thinking about like housing and poverty and things. How's that tackled in Australia?
I would say pretty much the same as at home. It's tackled pretty poorly and haphazardly, really.
Universally.
There are so many similarities. You know, you walk around Sydney, and it's like when I walked around London, you know, 20 years ago, or Leeds 10 years ago. You know, you see those pockets of real poverty and social, you know, deprivation. You'd see a huge amount of homeless people who really don't have access to the kind of services or care that they need, or really struggle to access the ones that are there. And it's very much the same. It's the same here. It's a bit sunnier, but really the problems are just the same, and the proliferation of them are the same, and the struggle from the state and federal government point of view to effectively deal with them is the same. It's
sad.
Yeah, no good news stories to share.
No, that's a shame. Yeah,
you know, and like everything else, there's pockets of really great practice and good things that are happening, and these little kind of shining beacons. Sorry,
it's all right.
These little shining beacons of where great things are happening, but you know, it's in a sea of mediocrity.
Yeah, sounds quite similar. Nikki, any thoughts?
I was just wondering if you could tell us a little bit more about your role, because it sounds really interesting.
Yeah, it is a really interesting role. And I have to say, I was talking to somebody else about this the other day, a friend of mine who's got a daughter who's just started her nurse training. And there was a couple of us there, another friend of mine who's a general nurse. And we were talking about whether or not being a nurse had a good career pathway.
Yeah.
And my friend who's a general nurse was arguing that she didn't really think it did. And I was like, I don't think that's true at all, actually. I think nursing a really, whatever branch actually you go into, there's really great opportunities in nursing. And I think back to when I qualified, I think I probably never thought that I would be doing the kind of job that I'm doing right now. Because I think I thought I would probably always work in a hospital, or I would work in a mental health setting, or in some ways be in that kind of public mental health system. And I'm not. I work for a not-for-profit. It's probably one of the oldest and most well-known charities in Australia, Lifeline. It's something that all Australians have heard of and kind of have known since they grew up with. It's been around since the 60s, and it is a crisis support and suicide prevention helpline. And that's what we do. We have like a million interactions every year, which for the Australian population is pretty significant. We're much bigger than any other similar service in the country, and I head up the clinical part of that service. So the team that work for me are responsible for the development of the training that our crisis supporters, who are the people that answer lifeline callers, answer our phones. So we're responsible for the development of their training and that whole skills basis that they have. And like it's an interesting kind of balance, because we are at the point of delivery, not a clinical service. The people who handle the calls and our lifeline, essentially, they're not clinicians, they're just people from any walk of life who've gone through our kind of 3-month training program, do this amazing work with people in crisis, really high risk. So at the point of delivery, it's a non-clinical service, and I think that's something that we organisationally kind of promote and are really proud of. But the reason that it's safe and effective is because there's a really strong clinical and evidence base to the skills we give people and the work that we do and the way we design and deliver and support the people who deliver the service. So kind of in the background, there's all this really important clinical stuff that happens. The team that work for me, and I also head up the learning and development team who do all the design and making the training look awesome and facilitate it and whatnot. So we kind of have this weird conundrum where we're on the face, not a clinical service, but behind and like a duck, all the busy making it all work and be safe and be effective. So, but it's a really awesome job, actually. I love it.
It's a good visual, that.
Yes. Yeah.
I do have a DM, direct message from Twitter, and it's a question about how's COVID-19 impacted in mental health in Australia and for Lifeline.
It's a really good question. We were just talking before we went live about the fact that as a country, Australia has actually got off really lightly from the whole coronavirus thing. The death and infection rate has been low, and we're really, from a kind of practical purposes, we're now moving out the other side. Kids are back at school, people are getting back to work. Financially, people are readjusting and thinking about what the impact on them has been. But the actual mental health sector, I mean, we have seen such an increased demand on all different kinds of services across the mental health sector, not just the not-for-profits and kind of informal services like mine, but statutory mental health services also seen a really significant demand. And I guess what we are anticipating is that this isn't really going to go away anytime soon. Like as an organisation, we're really preparing to continue to deal with this increased demand for months, really. Yeah. And it's interesting that what we're seeing is not necessarily an uplift in the calls about suicide. Like we're not seeing from the service we run increased levels of suicidality beyond the normal percentage of those calls that we are. But we're seeing a really significant increase in just a general level of anxiety and uncertainty. And I think it's really telling that, particularly in Australia, we've had coronavirus, we've had all the bushfires, that we've had some really extreme weather events that have resulted in loss of life over the last 18 months. And they're all like this series of quite unprecedented situations, things that people don't usually expect to live through in their lifetime. And we've had quite a few of them all in a short period of time. And I think when people are faced with this series of events, of things that they can't really control, it really has an impact on them. And I think there's a lot of global angst around, will the world ever get back to normal? What's it going to be like when I'm older? What kind of world are we bringing our children into? Like those really kind of big
Yeah.
kind of existential worries that you can't do much about seem to be really prevalent at the moment. And from our service point of view, that is the kind of things that people are presenting with, the kind of worries that people are coming with, how that sense of feeling a bit that life is a bit out of control.
So you're thinking about that in terms of your training around being trauma informed and thinking about the sort of trauma support that people might need in the future.
Yeah, we are. I mean, there's quite a few. We our service were asked by the federal government to set up a particular support line for the bushfire affected communities. We've been running that for a few months, and that does have a slightly different focus to our normal phone line, because the people who were in those bushfire affected communities, and I'm sure you would have seen some of the pictures on the news. I mean, it was just so horrendous. Like it was just some of the imagery and the things that people lived through were really shocking. And certainly here, it was on the news constantly. Like there was no getting away from it. And you know, people respond really differently to those kind of events, because you kind of have this period of time where they're dealing with all the very practical things about, you know, my house is burned down, I've lost all my identification documents, you know, entire livelihood in these rural places has gone. Like, people had these hugely practical things that they had to try and deal with. And it was like a month, 2 months later that we've started to see some of the real kind of psychological impact of living through that. And there were some bushfires about 5 years ago in Victoria where over 100 people died. I mean, it was horrendous. And there was a long-term study done by one of the universities after that, and they showed that people, even 5 years later, were still showing the mental health impact of living through that. And so I think as a sector, we've really tried to learn from that and to think about what do we need to put in place right now to stop that same cycle of things happening. So making sure that people have early access to psychological support, and it's there within the communities where they're affected, and they don't have to pay for it and they don't have to wait for it. And so in some really good practices has come out of those learnings from other really terrible things that have happened.
Yeah, so it sounds like Lifeline do some signposting as well as offering psychological support to services, which is quite similar to UK, isn't it? Crisis. And I know you worked in crisis services, didn't you, in the UK as well? I
did a little bit, yeah.
Yeah. And last night I was talking to a group of GPs on a different call, and we were talking about particularly medical practitioners switching to more digital and telephone-based interventions. And I mentioned that I was interviewing you today, and they were really interested in your kind of thoughts about the differences between sort of face-to-face interventions and speaking to people online, and any kind of, I guess, any tips you might have, and thinking about kind of how you can transfer those skills online.
It's really common here, and I think part of it is just the vast geography of Australia, that so many people live so remotely that they might not live within a 5-hour drive of a town. I think it's really hard to conceive of that when you come from the UK that is so densely populated, but there are people in parts of Australia that literally say to us we would have to drive a day to the nearest psychologist or something. Like, it's just mind-blowing. So telehealth has really been very established in Australia for a long time for all kinds of healthcare delivery, and actually probably for the last 7 years, even before Lifeline. I worked 5 years for a company that did telephony mental health services. We ran the statewide mental health triage, which is like the gatekeeping for all the mental health services. It's really common here. The population are used to ringing up to see help and expect that they might receive some of that over the phone, or increasingly through a video conference, Skype, something like that. And at Lifeline, our main delivery has been over the phone, so people call us. That's how they get support. But we also have a small online chat, and just recently text-based counselling as well, text-based support as well. So, and that is such a huge area of growth. Like the demand for the text service is way beyond what we can deliver. And our main focus now for the next year is to move that to 24/7 delivery, the same as our phone service, because the demand is so great. And what's really interesting about the text service is that it attracts a completely different population to the phone service. So Lifeline's quite traditional, and our average user is like a 50-year-old white woman, which makes me think, oh my God, that's me. But the demographic users for the text service are much younger, people in their 20s, or more men using that than use the phone service. And interestingly, above population percentages of minority groups, so much higher use from LGBTI groups, much higher use from people from culturally and linguistically diverse backgrounds, and significantly a much higher use from the Indigenous Australian population than use any other service. And I think the anonymity of text and the ease of use, the privacy of it all, like there's a whole bunch of reasons why it's really attractive to people who want to seek help in a very low key, very anonymous kind of way. Like you literally don't need to give away anything of yourself on a text interaction, and it's really freeing.
Yeah. So what strikes me with that is, and I'm thinking back to when I was involved in setting up some telephone support myself, and there wasn't much of an uptake of it from patients. And this was in a general practice setting. So what strikes me in what you've said is that Australian residents can obviously see the benefit of it because of the, vastness of the country, and therefore for them, kind of being able to use that service is obviously going to be more realistic than going for a face-to-face consultation. And the other thing that strikes me is I'm working with schools at the moment. So I was just thinking about what you were saying about text services, because we do work where children and young people can text, and it's really popular, as you've said. So I was wondering whether Lifeline is universal. Do you work with adults, or do you work with children and young people as well? Would they access Lifeline?
Yeah, and anyone can use it, like no boundaries or exclusion criteria at all. And we don't actually ask people, we don't ask them anything about themselves. Right. We don't for any data. So we only find things out anecdotally from, in a roundabout way for the things that, if a person tells us they're still at school, you can have a good guess at their age bracket. We tend to know because of that, really. We do. So we get contacts across the whole age spectrum. Yeah, but there are other services that are much more aimed at younger people. There's Helpline, which is pretty much the same service as ours, but is really pitched at young people, and they also have a text-based service, and that is really well used.
Yeah. And it was quite interesting what you were saying about the Indigenous populations using the text message. And I was just thinking generally, because there's starting to be some emerging research, isn't there, about learning from Indigenous populations and community. So I just wondered if you had any thoughts to share with us about that, really. Your experience working in Australia, what can we learn?
Yeah, it's really interesting, actually. It's been a bit of a steep learning curve for me. I think until you come to Australia, you don't really understand what the relationship is between Australia and the Australian Indigenous people, and how completely rooted they are in the kind of the history and the backstory of Australia, and how in some way how offensive and kind of confronting the relatively recent colonisation of the country's been, and what the impact has been on the Indigenous population. And it's so complex, and the mental health of Indigenous Australians is really tied up in that. I mean, the rates of mental illness and suicide are incredibly high among the Indigenous population, much higher than in the normal population. And the kind of beliefs of the Indigenous people are very much that in the way that the cause of the high levels of mental illness and suicidality is really related to the effects of colonisation and all the kind of many injustices that have happened to Indigenous people in Australia, that the solutions for those can't be imposed. And I think what's been happening in Australia for decades is that the state and federal governments and just services generally have tried to, with the best of intentions, impose their service models and their ways of working on Indigenous communities to try and fix these problems, and it failed every single time. And there's this increasing understanding and acceptance of the fact that Indigenous people they understand the root of the problems, and they have to design the solutions and implement the solutions, and the role of other services is to support and facilitate that rather impose. And I think that has been an important shift that has taken a really long time to happen, and for people to accept that we might not know best, that us, white people who run these very traditional services, that our solutions don't work. They don't address the causes of the problem. They're not the right solution. So it's a real challenge. But I think that we're kind of at a point now in Australia where people collectively understand that we need to hand over the responsibility for finding the solutions back to Indigenous people, because for them it's just all so closely connected to community and spirituality and the environment that they live in, and kind of based in the land. It's a completely contextually a different understanding of mental health and mental illness, and what the solution is. That they're in two different places. Yeah,
there's a lot of learning there, isn't there, that's very transferable around privilege and paternalism, and about us kind of needing to go into people's communities and work with them and understand things through their social context, and also about lived experience. That really strikes us, isn't it, about unless we've had lived experience, can we really understand what it's like for a person, and particularly all the sort of intersectional stuff around gender and race and culture and social class as well. So it's really interesting. I know, Nikki, you were quite interested in this aspect as well. So is there anything you want to ask?
Anything to start a fight, me.
Yeah.
I do have a couple of questions, actually. So one is a bit hard, one is a bit easy. So I'm going to go with the harder one first, I think.
Okay, go on. Let's hope I can answer it. If it's too hard, don't do it too hard.
It's a question about whether the bushfires happening before meant that people were exhausted and that COVID had a greater impact.
Good one. Yeah, good question.
Yeah, it is a good question, and I actually don't know. I don't know the answer to that. I guess the bushfires, even though I'm sure externally they were looked like the whole of Australia was on fire, it was actually kind of clustered in spots up and down, particularly the east coast, and the big metro areas like Sydney and Melbourne. We could see the smoke, but we were not really affected. It was these really small, regional, remote, tiny communities sometimes that were just so heavily impacted. So I think for the people who live there, who have in many cases lost everything, I think probably to have to deal with the whole COVID thing on top of that, I wonder if it even has really registered in a way, because yes, we've had lockdown and we've had isolation, but I think that for the people in those bushfire ravaged communities, their lives were probably so upside down and just struggling day to day, and nothing's normal, that they in some ways may have almost got through the whole coronavirus thing thinking, how can life possibly be any worse for us than it already is. So but I haven't seen a huge amount about it, but there is a lot of research happening in those bushfire communities again, and kind of follow up from the other one. It'd be interesting to see if any of the commentary from that in years to come has anything to say about the impact of this so closely after that, because it literally was. We went from, you know, bushfires at the end of January, and then 2 weeks later, we, you know, country was in lockdown. So
it's interesting. We're going to, I mean, human tragedy, you know, you can't touch that side of it, but there's something to be said a lot about kind of national identity, how we see ourselves as individuals, how we find meaning, and how that really does impact mental well-being. You know, this idea about what the certainties are. And again, as well, I think none of this stuff is going away, is it? It's likely that climate change will continue to be a problem. It's likely that pandemics will continue to be a problem. And the more that we can learn about how to support each other, the better, really, I think.
Yeah, absolutely.
The other one, which I think is a slightly easier question, don't worry. It's one of those it's very much, I won't say who's asked it, but it's one of those asking for a friend questions, from what I can see here.
Do they want a job?
It's about sort of the work that you do being so much online. I think a lot of nurses and educators have suddenly had to swing around when they used to really relying on the face skills. But is there any advice for building rapport on the phone?
That is a really good one. So our whole model that we use at Lifeline, our whole clinical model, is built around connection and engagement, and the sense that the most important thing that you can do in a conversation, whether that's on the phone or by text, is to genuinely engage with that person, to create a space where they feel safe and supported, and that we facilitate we allow them to share what's on their mind. And so we absolutely build all those really important active listening skills. Like, it sounds so trite, you know, we learn all that in our training or interpersonal skills, but actually active listening skills, the good use of things like reflection and paraphrasing and open questions, that's what we use. Like, our whole training is built around how you skillfully use those micro skills to build a connection with someone, to create a safe space, to enable them to talk about whatever is on their mind, to just sit with them in their pain and not feel the need to fix them or move things more quickly than they want to do. And all of that is really skillful. And I think actually, because we teach all that stuff to non-clinicians, it's much easier for them to do, because the most problematic people we have coming to work for Lifeline are people who've got a lot of skills, psychologists, people with a counselling background, because they're used to doing something a bit different, and we actually have to get them to kind of dial it back a bit. So for them, it's quite a challenge. But yeah, absolutely, the most critical thing is around engaging and building a connection with someone. And you've just got to be genuine in your intention there, to not rush, just to sit in that important bit at the start, which is around how do you make them feel safe and give them space.
Well, that's really comforting for people to hear, I think, because kind of the message, and correct me if I'm wrong, that you're giving there is that you already have the skills. It's about moving them into a different medium. So anything that people have in their everyday practice, they can just shift over. It's not a question of anything secret and new. Well, that's great. I have a question as well. Is that right? Sneak one in, Vanessa.
Yeah, go on. I'll let you.
Tell us about Vogue. Tell us about Vogue.
I was going to ask that, actually. So go on. Yeah, we're dying to ask you about that.
I know. It's we've had some comedy moments about me being in Vogue. Like, who would have thought, right? We were talking about at the start of our career, I thought I'd never be working for Lifeline. I certainly never thought that I would be. That's not what I went into nursing for. But actually, Australian Vogue did a series of interviews around women who work in healthcare in all different kinds of ways, who were part of an organisation that were dealing with the impact of COVID. So Lifeline were invited to take part, and they asked me if I would do it. So that's how I got to be in Vogue. And it was a really cool experience, actually. It was a really good interview. It was a really interesting time to talk to them, because it was right in the middle of lockdown, and we had this amazing photographer who's had his pictures in the New York Times turned up at our house, and yeah, we had some really funny moments when we knew he was coming. So my kids were like thinking of all the different ways that I could answer the door, because obviously we knew he was coming to take a picture about quite a serious thing, and they were like, "You should answer the door in your bikini. Maybe you should say, should by the pool? Do I need a cocktail? Should we ask him to do some family snaps while he's here?"
Oh, it must be so powerful.
Just so you know.
Yeah. I mean, it's such a beautiful, strong image of you as well, isn't it? The photograph, it's really strong.
Yeah, it is actually. I don't have many pictures of myself that I like, but that one is it's pretty awesome. Yeah.
You really need to get a copy of it for home. But yeah, I mean, I think what struck me about it was it's a really strong image, but it's also a really female image, because it's in your home and there's quite a feminine aspect to that photograph. So it got me thinking, really, and I guess this is why it's great in a way that Vogue covered it, because of them having such a strong female kind of followership, is just about leadership as a female. Do you think there are female characteristics of female leadership, or do you think leadership should be universal and not gendered at all? What are your thoughts on that?
I think there's a definite case to be made for strong female leadership, and I think it's really interesting now looking at the world. Like, honestly, who would you rather have in charge of your country? Jacinda Ardern, Angela Merkel, or Trump? Like, you know, I think that there are real examples of female leaders who are showing that you can be empathic and decisive and determined and be a leader, but be a leader in a way that you can bring people with you. So I definitely think that we should celebrate the characteristics of positive female leadership, and not feel like we have to lead like a man, because, you know, like, what does that even mean? Not all men are the same. It's such a kind of stupid comparison in a way, but I think that there are things that women as leaders think are perhaps more important, the stuff around bringing people with you, about having compassion and empathy for the people that work for you, for not wanting to kind of crush them all in an effort to get to the top, but actually to celebrate everyone's successes as well as your own. And that doesn't need to be a female thing either. Men can do that as well. But I think perhaps there's some of the things that probably women as leaders are intuitively a bit better at, about kind of bringing the people with you and that sense of team and kind of collective ownership. And so I think it's really important to celebrate all that, and also to just to show that we can be a parent and have a great job and be a fully functioning person in society. Like, it doesn't have to be, doesn't mean it's easy, but it doesn't have to be an either or thing. I always kind of think about that quote that does the rounds about there's this perception that you have to work like you don't have children, and you have to parent like you don't have a job, and that is the dilemma of a working woman. And as much as I kind of think it's true, I think it's probably something that we impose on ourselves as much as other people impose on us. I think we're kind of really good at putting guilt on ourselves, feeling guilty because, you know, we give the kids canteen money instead of making them lunch, or we don't get back in time to do something, or we feel like we leave work early to get somewhere. We're really good at just making ourselves feel bad about the fact that we're actually doing an incredible job. So I think learning about that stuff.
Yeah, no, I think that's a really great message, isn't it, for sort of females who are watching, and maybe people who are thinking about female leadership as a direction to go, that you can be female and a leader, and those things can go together, rather than having to lead like a man. And as you say, men are very different and diverse in terms of how they lead as well. We are up to the 45 minutes line, so I think it's a kind of good
fast
thing to end on something
quick.
Yeah, and I think that's quite a positive note to end on. Is there anything though, just before we end, that you want to say, just as kind of a takeaway message or an end of the interview kind of comment?
Oh, I wasn't ready to say any comments, but only that I've really enjoyed talking with you about this stuff. And actually, when you sent the questions through earlier, it did prompt me to think about some things I haven't really thought about for a long time, like what's the difference between how I used to work in the UK and here. And I think I've been away a bit too long now, so it was good. It was good for me to switch my mind back to think about some of that, but also to think just generally about a lot of the similarities, like. It's not really that different.
Yeah.
But the problems are the same. The work is the same, and the kind of the solutions and the good stuff is the same as well.
Yeah, that's great. It's been really, really interesting, and thank you for all your kind of answers and your honesty really as well. I'm sure lots of people have found that really beneficial and interesting. So just before we end, just need.
I have a message if that's okay.
Yeah, go on.
Dave has been on direct messaging me, so don't forget the things he said. And thank you very much, Rachel. It's absolutely lovely to see mental health doing really brilliant stuff. It's just lovely, really, really positive.
Thank you.
Yeah, I've got messages from Dave saying next week's session, Emma Wadey and Simpson talking about mental health research during COVID. So I think everybody's going to be looking at what we can learn from this experience been through. And also there's another Unite on Twitter. There's a health pension special at 5:30 if you've still any energy left for this. So pace yourself today. There's a lot going on social media. And thank you very much. Thank you very much.
Thank you. It's been great. Thank you.
Thank you.